Thank you all for joining us today. My name is Tim Hudson. I'm with the Michigan Opioid Collaborative. Our webinar today is Substance Use and Co-occurring Psychiatric Disorders. You see the QR code on the screen here for CMEs. We are going to post all the credit information you need to ensure you get your credits in a PDF. It'll be posted in the chat throughout the course of this webinar. Additionally, we will follow up with all attendees after this webinar and ensure you have it as well. You'll have 48 hours to request and complete the survey for educational credits. For those of you who just joined, or if you haven't done so already, please put your name, email address, and place of employment in the chat. So I want to start by talking a little about the services we offer at the Michigan Opioid Collaborative. We are a grant-funded program with the University of Michigan, funded by Blue Cross Blue Shield of Michigan and Michigan Department of Health and Human Services. We offer free same-day patient consultations with an addiction physician in areas such as MAT inductions and guidance, options for chronic pain, and obtaining community resources and referrals. We hold free monthly webinars, such as the one we're on right now, and case consultations around polysubstance use and treating different substance use disorders. Additionally, we host free education and trainings tailored to your office around substance use disorders, MOUDs, technical assistance, office setup, and general addiction treatment. We collaborate with Great Moms Model of Care to provide support around diagnosing and treating pregnant and perinatal patients with SUDs. We have a hepatologist on staff who provides education, case consultation, and a three-part webinar series on Hep C. And lastly, we participate in a number of community events focusing on community. I'm sorry. Thank you. We participate in a number of community events focusing on community coalitions to build connections and work to increase awareness of SUDs, the benefits of MOUDs, and reduce stigma. So I'll introduce our host for today, Dr. Jonathan Morrow. Jonathan Morrow received his MD and PhD in neuroscience from the University of Michigan, where he is now an associate professor of psychiatry. His laboratory research focuses on the neurobiology of motivated behavior, and since 2011 has provided medication management and other clinical care to patients through the University of Michigan Addiction Treatment Services. Dr. Morrow, the floor is yours.
Great, thank you. And thanks all for attending. I'm going to share my screen, and I do have some slides to go through. Yeah, that's the right one. Okay, so I'll be talking about co-occurring psychiatric and substance use disorders. And so what I'll plan on doing is give you sort of an overview of psychiatric comorbidity with substance use disorders, some kind of general strategies for approaching that, and then talk about some individual disorders later on in the talk. And we don't have to necessarily get to everything that I have on these slides, but if you have questions throughout this, please let me know and I can address those. Okay, so there we are. Okay, so first of all, this is why we're interested in this topic of comorbidity. It's very common. So there are, if you just look at people who are seeking treatment for substance use, a whole lot of them have co-occurring psychiatric disorders, and vice versa. There's something called Bergson's bias that can come into those kind of samples, where the sickest people are the ones seeking treatment, so that may not reflect what's actually happening in the community. But there's been a number of studies where they just did a random sampling of people in the community and seeing what their psychiatric comorbidity burden is, and it's still really high, even outside of a treatment-seeking population. So from these types of studies, we've learned that about 30% of people who have a psychiatric disorder also have a substance use disorder. And for people with a substance use disorder, the lifetime prevalence of some other psychiatric disorders is over 50%. So most patients will have a co-occurring psychiatric disorder. And so that's lifetime, but the 12 months, so just within a year, is also very high. For bipolar disorder, it's over a third of patients will have an active substance use issue in any given year. Major depression, 20%. Anxiety disorder is also quite high, although OCD is a bit of an exception there. So a lot of our patients will have this comorbid problem, both a substance use disorder and a psychiatric disorder of some other kind. And comorbidity will worsen outcomes for these patients. So this is, I guess it's kind of an outdated term, but dual diagnosis is what we call substance use disorder plus another psychiatric disorder. But those patients generally do worse clinically in all kinds of different domains. Just in terms of their overall functioning, their physical health, their outcomes in terms of the substance use disorder and the psychiatric disorder on their own, all of that is worse when you have comorbidities. There are some kind of interesting possible exceptions to that. There's some evidence for people who have severe and persistent mental illness. The addition of a substance use problem may not actually be as big of an influence on their outcomes as people with less severe mental illness. It probably doesn't worsen outcomes for antisocial personality. Outcomes are pretty bad for that anyway. And it's also kind of part of the illness, substance use. So it doesn't seem to actually worsen the outcomes for that particular disorder. Other kind of interesting tidbits is even subclinical depression. So if it's not meeting criteria for a major depressive episode, that's still going to worsen outcomes for at least for alcohol use disorder. So it's still important to address those kinds of symptoms. But conversely, major depressive disorder in remission does not worsen outcomes. So if it's adequately treated, it's as if they don't have their outcomes are as if they don't have a depressive disorder at all. So one question to consider is why comorbidity is so common. And there's a number of possibilities that have been put forward. They fall into some broad categories. One of which is basically some variation of that the mental health disorder is causing the substance use disorder in some way. So it's leading to the substance use disorder. The most popular of these kind of hypotheses is the self-medication hypothesis. So somebody has depression, anxiety, etc., and they will use substances as a way of treating their own psychiatric symptoms. So that probably plays into, we'll come back to that, but that probably plays into some of this comorbidity. It's also true that some patients will use substances to actually enhance their psychiatric symptoms. You especially see this with bipolar mania. If people like the manic feeling, they may use substances like cocaine or something like that to actually enhance that feeling. And I mentioned antisocial personality they're intentionally using substances to enhance their kind of symptoms there. There's also impaired judgment or appreciation of consequences with some mental health disorders. And so that may lead to more substance use just because they're just not making good decisions in general. So that leads to more substance use. So most of these so far have been, that's an explanation for more substance use. I think it needs an extra step to get to the addiction. And that's just that because you're exposing yourself to so much drug use, that leads to an addictive process. You're not automatically addicted just because you're using a lot of drugs. But the more you use, the more at risk you're going to be for that. But there's a theory of addiction called opponent process theory that essentially it's a pretty popular theory, but the idea is essentially that addictive behavior is caused by withdrawal. So you use the drug, you get tolerant to it, and then your capacity for pleasure or whatever it is actually decreased because of the substance use. And then you actually need more and more substances just to get to a normal level of feeling. So if that's and it's debatable how big a role that plays in the actual addictive process, but if that is playing a major role, then there's some types of psychopathology that can exacerbate those withdrawal symptoms. So so if that were the case, then the actual mechanism of addiction would be enhanced by the fact that they have a psychiatric disorder as well. And there's also a sensitization of the reward circuitry with various forms of psychopathology, mostly because this is a stress effect. Mostly, it's just you're under a lot of stress. The psychiatric symptoms are distressing, so that activates the stress system, which cross sensitizes with the reward circuitry. So that's going to enhance the effect of drugs on that reward circuitry and lead to more addiction, just because you're in this constant state of stress. So that's that one broad category of explanation. Another one is that the substance use, having a substance use disorder, can in some way cause a mental health disorder to develop, and that can happen in a number of ways. One is that you can get psychiatric symptoms from chronic intoxication or withdrawal. We would classify that as a substance-induced mood disorder or anxiety disorder or something. When we'll talk about how to differentiate that from a separate disorder. But certainly you can get a lot of psychiatric symptoms just from the direct effects of the drug. There's also long-term neuropsychiatric consequences of substance use. You get, for example, damage to the prefrontal cortex, sometimes enhancement of subcortical, like basal ganglia structures and whatnot, that could contribute to a psychiatric disorder in the future. One example of this is psychotic symptoms can develop after long-term use of stimulants. And even after you stop the stimulants, it can take years for that to resolve. It typically does resolve if that's really the cause of the psychosis, but it takes a long time, and it puts the person probably at higher risk for those types of symptoms in the long term. And there's sensitization of the stress system, the HPA axis, hypothalamic pituitary adrenal axis. Drugs of abuse will sensitize that stress system. And so that sensitized stress system is going to be more susceptible to different psychiatric disorders, depression, anxiety, a lot of things you're going to be at higher risk for if you have a hypersensitive stress system. And finally, in this category, you just increase your exposure to traumatic and stressful events by the fact that you're using drugs. A lot of times it's illegal drugs that will expose people to illegal activities. They're also going to be more at risk when they're intoxicated or something else like that. So they're just going to be more likely to undergo some kind of trauma, which could lead to psychopathology. But there's also a category of explanation that there could be a common cause. So people, there's some inherited vulnerability to substance use, and there's overlap with other psychiatric disorders. So people who are more vulnerable to substance use may also be more vulnerable to other types of psychiatric disorders. So maybe that's why they get so much comorbidity. There's also environmental, developmental factors like early life stress is going to put people at risk for substance use, but also for a number of other psychiatric disorders. And of course, there's also the possibility for an individual patient that these two disorders are unrelated to each other. It's just that when we look at the prevalence of mental health disorders and substance use disorders, if you just look at the overlap that you would get by chance, the actual prevalence is much higher than that. So that argues that one or more, probably all of these different explanations are contributing to individuals getting these comorbid conditions together. Okay, so I'll talk a little bit more about this self-medication hypothesis, because like I say, that is the dominant explanatory model for comorbidity in general. But I'll tell you, my reading of the literature, that explanatory model relies pretty heavily on anecdotal evidence. It makes a lot of intuitive sense. Patients will present their story in this way, but there's not a lot of evidence that you would expect, kind of scientific evidence, that if self-medication was really driving the use, you would expect, for example, specific drugs to be used for specific symptoms. So someone with an anxiety disorder, if they're trying to treat their anxiety disorder, cocaine would be a bad choice, right? so you would expect they would not use cocaine for that. But there's not a lot of evidence for anxiety disorders preferring opioids, for example, over cocaine. It seems to be kind of a general interest in drug use that develops. So, but there is some evidence that treating comorbid psychiatric disorders will improve substance use disorder. I mean, you certainly would expect that if the self-medication hypothesis was accurate. But honestly, those are pretty inconsistent results. There's a lot of studies that try to treat the comorbid psychiatric disorder and really see no difference in the substance use disorder outcomes. So I think this probably plays a role in comorbidities, but I don't think it deserves the kind of dominant status that it is. Probably not driving like the vast majority of this use. I think there's other factors at play there. So okay, we'll get more into, unless there's questions about that, we can get more into some kind of practical things. So there's some diagnostic challenges that come with just figuring out what's going on with if someone has psychiatric symptoms and substance use at the same time. So one piece of advice I would say is to screen comprehensively. You're not going to know something's there if you haven't asked about it. So if somebody has a substance use disorder, Make sure you're asking about trauma so that you can screen for PTSD. Ask about their eating disorders, like a lot of different psychiatric disorders. It's very common in this population, and it's also common to miss it because you're focused so much on their chief complaint or the most prominent thing that that they're using a lot of drugs. You also want to consider the effects of intoxication and withdrawal of the specific drug that they're using. So, for example, with cocaine and stimulants, part of the withdrawal syndrome is depression, and it can be a very profound depression. That's a pharmacological consequence of just not having the stimulant on board. So, if they're complaining of depression and they're using stimulants, you want to kind of get a timeline of those symptoms, and is this actually matching up with withdrawal or not? Similarly with psychotic symptoms or something, cannabis will cause psychotic symptoms and intoxication. Stimulants will as well. But on the other hand, heroin is not going to do that, right? Opioids don't have psychosis as part of their intoxication. So if you're seeing psychosis and you say, well, they're using drugs, so we can't really. Well, if they're just using heroin, that's not really an explanation for this psychosis. There's probably something else going on there. You also want to consider metabolic disturbances, head trauma, all the regular things that you would also consider with psychiatric disorders. You don't want to forget about those things because because they're also using drugs. It doesn't mean that these other things haven't happened. It actually might make it more common for them to have these consequences as well. And asking about the timeline of the symptoms can be very helpful. So if somebody has what's very useful in their history is a period of sobriety. If they've had these symptoms during a long period of sobriety, that is an argument for a separate psychiatric disorder in addition to their substance use. It's not just the consequence of intoxication and withdrawal. So if they were sober for a year, were you depressed during that year? Were you depressed before you started using? Sometimes you don't have that information because it's like, I was using since I was 11 or whatever, maybe that's not there. But if you do have that, that can be very useful. And I said, and the abstinence needs to be extended. For most drugs, that's going to be at least 4 weeks of abstinence before you can say anything about their psychiatric disorders. And for a lot of drugs, it's longer than that. Cannabis takes like 3 months to get out of the system. Benzodiazepines, that can be a year or even more before they're done with the extended withdrawal period. So. Family history can also be helpful. And for some disorders, examples I give are PTSD, eating disorders, there's really not a lot of overlap with drug effects for that. So don't delay the diagnosis while you're trying to figure out, do they have a sober period? If they're having flashbacks and nightmares, that's PTSD. That's not a consequence of the drug use. Okay, so now some dual diagnosis, quote unquote, treatment models that have been used. We'll get into this a little bit. This is kind of a general strategy. How do you approach somebody with both a substance use and a psychiatric disorder? So one approach is sequential treatment. And so that means you're going to try to stabilize whatever condition is most acute first. So the substance use, you say the substance use is out of control. And so let's just stabilize that first, and then we'll deal with the depression or the anxiety or whatever it is. This is a common treatment model. The problem with that is that it doesn't address the interrelationship of those two disorders. The depression is to some degree influencing the substance use, and vice versa. So if you try to get the substance use under control without addressing the depression, number one, that's going to make no sense to the patient. And it's also not going to be very effective most of the time. So what the preferred treatment model is some sort of integrated treatment. Ideally, you would be addressing both these disorders, or if it's however many disorders, you're addressing that at the same time as the substance use. Ideally, the same treatment team could address both disorders. Like I said, this is the preferred way of doing it. Problem with that is that it requires staff who are trained in all of these different modalities, which just isn't that, that's not always realistic that you're going to have people who have expertise in all of that. And so the next best thing would be parallel treatment, where you're still addressing both the substance use and the mental health issues, but it's different treatment teams that are doing that. If you're going to do that, communicate. That's essential. Each one needs to know what the other is doing because they're related to each other. And it's important that you discuss the treatment philosophies and approaches, because if you're having contradictory approaches from the two treatment teams, that can be very confusing to patients, and that can disrupt care. So, for example, one is really focused on abstinence, and the other is more open to moderation or something like that. You need to be on the same page with the patient, whatever that ends up being. So I'll just give some examples of integrated therapy that has been examined in the literature. So there's some programs that are developed specifically for this. For example, there's for PTSD, there's something called Seeking Safety, that is a therapy method that is designed specifically to treat both substance use disorder and PTSD at the same time. There's a number of these. I won't talk that specifically about Seeking Safety. It's just an example of one of these types of intervention. There's also exposure therapy for PTSD that's been shown to work well, and there's evidence now. So there's a lot of anecdotal evidence, and I could give you my own stories about people's psychiatric issues being exacerbated, or their substance use being exacerbated by exposure therapy for PTSD in particular. And that's because it's part of the therapy, you're intentionally triggering the PTSD symptoms, and so that can destabilize people. But there's been a number of scientific, I just put two here, but there's been a number of scientific studies that have looked at that question, and there's really no evidence for exacerbating substance use with exposure therapy. The substance use tends to improve with exposure therapy. And in fact, if you just focus on the substance use without exposure therapy, they actually get more of an exacerbation in those kind of control groups than in the ones who got the exposure therapy. So don't be shy about using the best evidence-based intervention along with your substance use treatment. That's probably going to get you the best outcomes. There are some other ones. So there's an integrated group therapy for bipolar disorder that's been studied. Assertive community treatment. I'll kind of move through these. There's motivational interviewing that's been specifically adapted for dual diagnosis patients. There's family interventions. So contingency management has been studied in this population, but the effects on substance use are pretty clearly positive with contingency management, but effects on psychiatric outcomes have not been as consistent with that one. 12-step facilitation, generally speaking, has not been very impressive in this population. It works without the, without the comorbidity aspect, but it doesn't seem to do much for psychiatric symptoms. And there has been at least one study showing integrated CBT for that was designed to address both anxiety and alcohol use disorder, improved outcomes for both of those disorders. So there's some integrated therapy methods that can be used to treat these different problems simultaneously. So peer support, I mentioned 12-step facilitation, but self-help groups in general, they seem to improve outcomes for dual diagnosis patients, pretty similar to the way they seem to improve outcomes for other patients, for just substance use disorder. It's a little hard to study these groups scientifically because it's hard to get controls. You can't really randomize people effectively. The peer support is not standardized, so there's always caveats that go with this. But as far as we can tell, the AA and similar types of groups do seem to work for dual diagnosis patients. And I feel like it's helpful to point out that AA literature, so the AA community has been, that's Alcoholics Anonymous, I guess I should say, in the past, at least historically, they've been, some of them anyway, a little bit hostile towards treatment of psychiatric disorders, especially with psychiatric medications. There's some history behind that makes sense. But if you encounter any of that kind of pushback, or your patients are encountering that pushback, this can be useful to point out. There's official AA literature now that endorses psychiatric medication when appropriately prescribed. I think the community has come around quite a bit on this, but you still have some folks who remain skeptical of psychiatric treatment. So, and there are some self-help groups specifically for people with comorbid psychiatric disorders. I gave some examples here, but that could be helpful for patients where that seems to be a big focus of their treatment is the dual diagnosis aspect of it. Okay, so that's, I think that's the end of my kind of general strategies for comorbid psychiatric disorders. So if there's any questions about that, I can take it, and otherwise I can move into some more specific strategies for specific disorders. No. Okay. So first up for that, so I have major depression. So we can just address, somebody has major depression and substance use disorder, both active at the same time. The literature is pretty clear that antidepressants are effective in major depression, even if there's active substance use going on. They're not going to be as effective, so that matches with these findings that at least a week of abstinence is going to increase the effect size for the antidepressants. So that tells me that the antidepressant works for major depression, but the substance use is going to interfere with that. It's not going to eliminate the efficacy, but it will interfere with it. And so, generally speaking, I would start so if somebody has a lot of depression, I would just start them on an antidepressant, some good treatment for depression. Maybe you can use therapy as well. and just talk with them about the fact that the substance use is going to interfere with the efficacy of that. That means get them to a good dose on that medication and then work on the substance use piece, as opposed to pushing that dose to really high levels, augmenting it, switching to another antidepressant because this one wasn't working. Then the patient's cycling through all these different antidepressants because they're not, and deciding that that doesn't work for me. You've got a perfectly good explanation for why your treatment isn't working, and it's the substance use. So get them on a good treatment and then address the substance use until you can get some abstinence and see if that first intervention, that first antidepressant may be perfectly fine for them. You got to give it a chance with some abstinence. And so, and some of these studies have indicated that the effect on substance use outcomes depends on the efficacy for depression. So, so to the extent that it improves their depressive symptoms, it may also help them with their substance use issues. There's some interesting research that suggests that SSRI effects on alcoholism may depend on the type of alcoholism that they have. There's different ways to classify alcohol use disorder. So there's something called a type A alcoholic. It's debatable how real these categories are, but there were a few studies all from one group, but there are a few studies that show that this type A alcohol use disorder, which has a late onset and less severe illness, that tends to improve with the addition of SSRIs. But on the other hand, there's a type B alcohol use disorder that has more early onset, severe alcohol use, and antisocial traits like criminality. It also tends to be more familial. So the prototypical would be a man with bad alcohol use disorder. His father had alcohol use disorder. His grandfather had alcohol use disorder. There's one family in these studies that was traced back to colonial times, and they find that their relative was in the stocks for being drunk and stuff. So if there's really strong family history associated with antisocial, that type of alcohol use disorder actually might get worse with SSRIs. Like I say, it's debatable how real these different types are. But really no one outside of that one group has replicated this finding, but that one group has replicated that finding a few times now. So it's worth keeping in mind. Opioid maintenance therapy can actually resolve depression by itself sometimes. So there's some thought that prolonged use of opioids will cause dysregulation within the opioid system, and that could lead to kind of a chronic opioid deficit, which manifests as some depressive symptoms, among other things. So sometimes when I'll have somebody with lingering depression on buprenorphine or something like that, I will just increase their buprenorphine dose, and that resolves the depression sometimes. Naltrexone, disulfiram, these things are as safe in this population as they are in other populations. Another thing to keep in mind with depression is smoking cessation. So you definitely want to encourage people to stop smoking, but you want to warn them of what that's going to be like. And one of the things to warn them about is that that can trigger depression, both because you get the withdrawal effect from the nicotine, and nicotine it's kind of a weak MAOI, so it's a bit of an antidepressant in and of itself. So that can actually worsen their depression. So that's something to just plan for if somebody's going to quit smoking. Overall, they're going to be better off if they quit smoking, but it's just something to be aware of. Okay, for bipolar disorder, as I mentioned, it's very common. Substance use within bipolar patients is extremely common. That's like one of the highest comorbidities there is. But there's not a lot of well-controlled studies. And this is true in general for comorbidity studies. We study the interventions for psychiatric disorders, but they almost always will exclude people with substance use disorders, and vice versa. Studies of substance use disorder will exclude people with other psychiatric studies. So you don't get a lot of studies of the actual comorbidity, which is unfortunate. But so a lot of what I'm saying is based on like one study or a couple of studies, but this is what we have in the literature. But there is some indication that lithium can be effective for both bipolar and substance use outcomes. Carbamazepine has been shown to improve both bipolar and cocaine use. Valproic acid may improve alcohol outcomes in bipolar patients. So all of those can be good interventions. Topiramate, there's reason to believe that topiramate would be particularly effective, but it doesn't, at least from the studies that have been published so far, topiramate does not seem to be effective in this population for substance use. Quetiapine has actually probably been studied the most, and generally speaking, no effect on substance use outcomes. Disulfiram is worth mentioning. Disulfiram can exacerbate psychosis. That it actually raises dopamine levels because it inhibits metabolism of dopamine, and so that can exacerbate psychosis from a lot of different sources, including bipolar disorder. So if somebody has bipolar disorder or psychotic disorder, I would not use antabuse with those folks. Naltrexone can induce mania. So if you go through opioid detoxification and then you start naltrexone, make sure they're on a mood stabilizer, because that can actually induce a manic episode potentially in these folks. And naltrexone can also cause more nausea in manic patients, so that's also something to keep in mind. All right, for anxiety disorder is a big issue, treating anxiety with some of the substance use disorder. And I think the real difficulty with treating anxiety disorders is the benzodiazepine problem. Benzodiazepines are very effective, at least short term, for anxiety disorders, and very problematic in a substance use population. I mean, it's a substance of abuse. So in general, I would just avoid benzodiazepines across the board for these folks. There are some circumstances where benzodiazepines are quite useful clinically. I think that's for short-term use. And the problem is that it works in the short term so much better than anything else we have to offer. You're never going to beat that with the patient. And if you continue that long term, they're going to get tolerant, and it's very likely to become an issue in terms of treatment, if not developing a separate benzodiazepine use disorder. So I would just look for some other method of controlling the anxiety. And there's standard ways of addressing anxiety, only some of which have been studied in this particular population. But buspirone has been studied. It's been a number of studies on that, and that does seem to improve both generalized anxiety and substance use outcomes. Surprisingly enough, SSRIs have really not been studied much in this population. It seems like an obvious thing to study, but it just hasn't been studied. Presumably it works similarly, but we don't know that for sure because it hasn't been tested in this population. Disulfiram and naltrexone both work in people who have anxiety disorders, so you can use that with them. And a good thing to keep in your back pocket is that smoking clearly increases risk for panic disorder. So if somebody has a panic disorder and you're looking for an intervention that can bring them some relief, have them quit smoking, because that will almost certainly improve their symptoms. It's actually a very large effect. Okay, schizophrenia. So schizophrenia, very highly comorbid with nicotine use disorder. It's about 80 to 90% of people with schizophrenia will smoke nicotine, and they tend to use high levels of nicotine. And there's a thought that this is self-medication because nicotine will actually improve symptoms of schizophrenia, and particularly symptoms that are difficult for us to treat with standard antipsychotics. So sensory gating, negative symptoms, they don't respond to a lot of our antipsychotics, but they do respond to nicotine. So it's possible that people with schizophrenia are actually self-treating with that. But there's also some evidence that early nicotine use might increase the risk for schizophrenia. So there might be some bidirectional relationship that's contributing to that comorbidity. But it's important to treat nicotine in schizophrenia and in general in people with psychiatric disorders, because that is a major cause of morbidity in this population. In fact, with substance use disorders, most of the deaths are from nicotine. It's not from the alcohol or other things that we tend to focus on more. They're actually dying from nicotine use. So don't forget to address that with these folks. Cannabis has an interesting relationship with schizophrenia. It clearly will exacerbate the symptoms of schizophrenia. It exacerbates psychosis in general. It can cause psychosis all on its own. So that's very clear. It's been a little more controversial whether it can cause schizophrenia. It definitely, I think it's pretty clear from the literature that it precipitates early onset. So if somebody's going to have schizophrenia and they use cannabis, that will cause them to have their first episode sooner if they use cannabis. I think it's also very clear that cannabis increases the risk of developing schizophrenia. And in fact, it looks like it increases that risk by about 40%. It's hard to do these studies because it's hard to say if somebody's using cannabis and they have schizophrenia, well, were they using the cannabis because of the schizophrenia, because like there's some shared vulnerability there or something like that? Would they have used it anyway? But there's been studies showing an increase in cannabis use, like population level studies, increased use in cannabis, or even more convincingly, an increase in the potency of cannabis in an area, and that the rates of schizophrenia increase right in line with that. So that tells me that it's probably a genetic vulnerability. There's just some people who would not have developed schizophrenia if they had not used cannabis. It's not a lot of people, but on a population level, it's actually a fair amount of schizophrenia may be caused by cannabis. Okay, yeah, we still got 2 minutes. Okay, so behavioral addictions, very common comorbidity. These are things like pathological gambling, internet gaming, compulsive sexual behavior, things like this. The neurobiology is almost identical to substance use disorders. So that's probably why there's so much comorbidity, that just the pathology is almost the same. So there's just a lot of overlap there. And natural rewards will cross-sensitize with drugs. There's a lot of evidence for that. And there's also a shared genetic basis for this. So it's going to be very common in this population. It's difficult to get a specific treatment for behavioral addictions. There's not many people who actually provide evidence-based care for behavioral addictions. And really, honestly, there's not a lot of evidence-based interventions that you can use. Most of the interventions are going to be, almost all of them are going to be psychotherapy, pretty similar to what you do with substances of abuse. it's a little complicated, a little more complicated just because these things are so available all the time. But of course, now with most of the drugs, that's almost the case with the drugs as well. Can't really get away from them in some areas. Okay, so a couple notes on borderline personality disorder. There's a lot of personality traits that go along with this. There's neuroticism, impulsivity, cue reactivity. All of those are part of borderline personality, and all three of those are strongly associated with substance use vulnerability. So highly comorbid with substance use disorders. More than half of borderline personality patients also have a substance use disorder. And in a treatment-seeking population for substance use, more than half of them may have borderline personality disorder. So you can see this a lot. It's important to recognize that people with a substance use, an active substance use disorder, may have impaired coping skills because of their active substance use. Once that clears up, they may not have those personality issues. So I would be cautious about diagnosing someone de novo with a borderline personality disorder if they haven't had a period of abstinence. But it's also true that it's just very common in this population as well. Any social personality disorder related to borderline personality disorder. Rule breaking is part of the disorder, and so some of that rule breaking can be substance use. Very highly comorbid. It's like over 90% comorbidity with addiction. And there's not really any known treatments for antisocial personality disorder. There's one study that showed CBT had good outcomes, but it hasn't been replicated. There's not really a good solution for folks with antisocial personality disorder. And I think we just have a couple minutes left, so I'll just go to, so eating disorders also highly comorbid with addiction. That can be things like stimulants, caffeine, nicotine, that can be used like in the service of the eating disorder. Though most commonly it's going to be alcohol. And that relationship can vary depending on whether it's anorexia or a binge eating disorder. That can vary the relationship. It seems to be separate etiologies for these in terms of the pathology. The addiction is kind of a lack of prefrontal control, lack of executive control over urges, whereas for things like anorexia nervosa, it's like too much executive control. So what that translates to clinically is you really need integrated treatment, because you can improve some of the things that we do to improve substance use disorder through therapy can actually make the eating disorder worse, because you're enhancing their control, and vice versa. You're trying to get them to let go of some of that control. That could actually increase their substance use if they're not being treated at the same time. Okay, so I think we're about at the end of time. So I'll just give you some summary statements here, some takeaways. Number one, remember to screen for these for psychiatric comorbidities. You can't treat what you haven't diagnosed, so make sure that you're looking for it. You definitely want to use integrated treatment as much as possible. If you can't do that, use parallel treatment, but please try to communicate as much as possible between providers that you're on the same page. And don't withhold treatment for one disorder while prioritizing the other. Just you want to address both at the same time. That's going to get you the best outcomes. And that's all I had. So thanks for your attention.
All right. Thank you, Dr. Morrow. Looks like we're right at 1 o'clock here, so we'll wrap up. I want to thank everybody for joining us here today. Behavioral health consultant from our Michigan Opioid Collaborative team will be reaching out to you shortly to introduce themselves and provide a copy of the slides. And they'll also send information on the on obtaining credits for this webinar. Thank you all and have a great weekend.